We all know that bifurcation is absolutely a different lesion subset because we not only have to look after the main branch, but it's a side branch, which is the Achilles heel. So basic objective of this session is to look at the side branch. What are the predictors of side branch occlusion, or so that we prevent this from happening while we are attempting the bifurcation stenting. At the same time, we also are going to see there are certain burning issues, whether when we are doing a provisional stenting, whether you should be dilating finishing it with the final kiss or not. So what I'm going to do is I'm going to present a couple of cases, and I'm going to build up the session. I'll show these cases, and at the end of these cases, I will have two experts who will give their views. We have Dr. Sanjeev Roy, who's going to speak on the side branch assessment and provisional stenting. And following him, Dr. Sangatvel will come. He'll talk, will I kiss all provisional lesions? Does imaging help? Now, I will then give a rebuttal on my cases as to what happened. And I will show you how I tackle the problems which I faced during the stenting of these bifurcation lesions. So we'll also have one of the guest lectures by Little Johnson, Imaging Guidance in Bifurcation Lesions, and we'll, of course, be left with some time for discussion. So I would request all the experts and the chairpersons to take an active part in the discussion. So I will start the session by showing the cases. All right. We get to see bifurcation lesions in about 15 to 20% of the patient, and as I mentioned, the intervention in these patients is complex and challenging. We all know that single stent strategy is beneficial, but in some patients, we need to go with 2 stents, which is about 25 to 30%. The problem is there are challenges in the anatomy because you will have variable plaque burden. The diameter of the side branches are going to be variable. You have different bifurcation angles. And there is certain dynamicity which comes with the procedure. Post-procedure, there's the angles change, the plaque shifts, the carina shifts, and as mentioned, side branch is the weakling. So provisional stenting has been, it's a kind of a treatment philosophy. Is it a true bifurcation? If the answer is no, you go ahead with provisional stenting. If the answer is yes, is the side branch suitable for stenting? No, you go ahead with provisional. If the answer is yes, you need to see the side branch. This is as per the EBC 2022. If the disease extends for more than 10 millimeter, if the answer is no, provisional. If the answer is yes, you select 2 stents. Well, very simple, provisional stenting. Step 1, 2, 3, wire both the vessels, dilate, stent, stop. Yes, that is where the provisional stenting ends, but if something goes wrong, you need to get back. If the side branch is pinched, you may go back, you may do the final kissing, but this is not sacrosanct. It basically depends on what kind of results you produce, what kind of branch it is, and I think we are going to have a lot of discussion in this. So I'll come to my first case. This was a 65-year-old male patient, diabetic hypertensive with chronic stable angina with a positive TMT. He had moderate LV dysfunction. We did the angiogram, and he had prox circumflex occlusion. There was a plaque in the distal left main and nostril stenosis of the LAD. The distal LAD looked pretty good size and nice. The right coronary artery was stented earlier and was flowing well, no problems there. So we decided to go ahead with stenting. Opening the distal part of the circumflex wasn't a major problem, so we opened that. We went ahead and did the OCT. First run was taken from the LAD to the left main. Now, to save time, I'll just go and tell you as to what all we observed in this run. Well, the ostial part of the LAD had a lipid-laden plaque. This was the distal edge of the origin of the circumflex branch. And as you can see, the distal edge has got a little bit of plaque burden. This was the proximal edge, which had even more plaque burden. And this was the left main, which was also distal left main, which was also diseased. Then we took a run from the circumflex to the left main. This was done prior to stenting the distal circumflex, which was occluded. So that's why the distal circumflex is not seen to be filling very well. So All right, I'll go to the still images. You have the circumflex ostium. Now this is uh, just at the origin of the LAD branch. You can again see a little bit of plaque burden here and the distal left main. Well, we stented the distal circumflex first, and then we went ahead with the provisional strategy. We, I think, chose 2 stents. We stented the LAD, and then we did what we kind of post-dilated the distal left main, and patient had severe angina, and there was occlusion of this side branch. So there was something wrong in the assessment of this vessel, and which probably led to occlusion of the side branch. This ends the first case. So what I've shown you here is an acute occlusion following provisional stenting in a vessel where there were certain features, there were certain predictors that this side branch is going to occlude. Well, I'll come to the second part of the talk, and I'm going to show you 2 cases. These are both cases which underwent provisional stenting. In one of them, we went ahead and did a KISS, and the other, we did not do the same. So we are going to look at the patency of the side branches. The first case is 65-year-old female, diabetic hypertensive with dyslipidemia, had anterior wall STEMI. She came with cardiogenic shock with EF, which was very low. She definitely had distal left main occlusion involving the ostia of the circumflex and the LAD. The RCA was absolutely fine. Since the patient was in cardiogenic shock, we put a balloon pump. This case was done in 2015, I think. So we went ahead and stented the LAD and then put an additional stent from the LAD to the left main. This was post-dilated. There was slight plaque shift into the circumflex, but we were happy with the result. We didn't want to go back and finish with a KISS, so we let it be. And about a year later, this lady comes back with chronic stable angina. She was initially put on optimal medical therapy, but there was not much relief. She had rest pain, so we brought her back to the cath lab, and we knew what we are going to be seeing. So circumflex was kind of hanging. This happened within a year of the primary plasty. RCA was absolutely fine. So what I'm showing you is that we did a primary angioplasty with a crossover stenting. There was a little plaque shift. We didn't go ahead and do anything to the side branch, and this lady comes back with the side branch occlusion. Case 2 was done in 2018, a 51-year-old male patient, a hypertensive with class 3 angina. He had normal LV function. We did an angiogram, which revealed left main to be normal. The circumflex appeared normal in the caudal views. He had segmental stenosis of the LAD involving the osteoproximal as well as the mid part of the LAD. And if you see the cranial, areocranial view, there is a plaque or a tight stenosis which is involving the ostia of the LAD. So RCA also had a mid-segment plaque, and there was disease in the ostia of the RPDA. So we went ahead, dilated the LAD, both proximal and distal. There was a little bit of dissection and some spasm noted at the left main. As you can see, the guide is kind of hugging the left main segment. We dilated, we we did a crossover, first the distal LAD, and then we stented the proximal LAD and with the port and optimized the stents. And this was the final result. The circumflex had a considerable plaque shift. Patient had chest pain, and we went ahead, we opened the strut, and then we went ahead and did a kissing balloon inflation. This is the iliocaudal view. Looks good here. The circumflex looks fine. In iliocranial view, there appears to be a slight chink there. We went ahead and stented the RCA also with good results. So follow-up 4 years later, this patient comes back with mildly positive TMT, and we took him up for CART because we wanted to see what the results are. Circumflex flowing absolutely fine. There was absolutely nothing wrong with the circumflex, so was the LAD. The stent was patent and flowing well. There was little slow flow, which we saw here in the cranial views. But everything was fine. The RCA was fine. We were a little concerned about the RPDA, but the RPDA continued to flow. The plaque had not shown any progression over a period of time. So what I have presented to you in the section where we had a long-term follow-up for provisional stenting. I showed you one case where post-provisional side branch was lost, and I showed you two cases where we did follow up a provisional stenting. Case one was a female diabetic hypertensive with dyslipidemia. She had presented with STEMI with distal LM Medina 111. She had a wide bifurcation angle. Main vessel side branch ratio was about 1.5. She had struts across the side branch which were not cleared. What I mean is that final kissing was not done. And what we noted at follow-up, that she had branch occlusion. Case 2 was a hypertensive with chronic stable angina. He had 001, that is what on angiography. The imaging was not done for either of these cases during the acute stage. He had a narrow bifurcation angle with a main vessel side branch ratio greater than 2, and the underwent a final kissing, and there was no side branch occlusion in this on follow-up. Now, I pose these questions to the speakers who are going to come, and we are going to have a healthy discussion on this. How do we assess the side branch is the first question. Are there any predictors of side branch occlusion after the provisional stenting? Is there a role of imaging for the side branch assessment? And when, how do we perform the kissing balloon inflation post provisional stenting?